mean, quality of life for someone who suffers cardiac arrest will never be any better than what it was before they went into cardiac arrest. Grandma's
Correct.
gonna, grandma who's demented and has recurrent pneumonias and UTIs is in that hospital every month. When she finally goes into cardiac arrest and we resuscitate her, she's still going to be grandma who's demented, is going to have pneumonia, UTI every month. She's not going to be any better than her pre-arrest baseline. I'm sure TV and movies have played into this idea that, CPR's for everybody, because in all the TV shows, the success rates are like 80, 90%.
Of course.
In reality, across the board in this country, the average is about 9 to 10% good resuscitation, good neuro outcome.
Wow.
So it's vastly different than what people are seeing on their TV or in the movie theaters all the time.
Yeah.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks as always for downloading this episode. Don't forget to check out not only this podcast, but my other podcast as well. That podcast is called the How Not to Kill Your Patient podcast. It's a podcast I do with Dr. Lisa Wolf. It's a little bit more clinical, but if you dig this podcast, you're going to dig that one as well. Now, I always remind you, if you haven't done so already, leaving a rating and review is a great way to help out the podcast. By leaving a rating and review, it helps other nurses like you find this podcast. And always don't forget to share it with your friends, your teammates, people you like, people you don't like. Share it with everybody. My episode today came to me when a young nurse that I work with came to me just after taking ACLS, and she said she didn't really feel like she learned as much as she expected from the class. I think that's probably not super uncommon. So I wanted to do a little bit of a deep dive into ACLS and talk a little bit about the medications and talk a little bit about the algorithms. I figured the perfect person to talk to would be Andrew Bowman. Andrew Bowman is a nurse practitioner. He's been on the podcast before. I'll put a link to the show notes to the episode where we learned more about just him. But he is a resuscitation guru who looks at all the research around ACLS. So we're going to do a deep dive into the algorithms and some of the medications that we use in ACLS. You are going to really dig this episode. This one's going to be a two-parter. We got a little long on this one, so it's going to be a two-parter. I'll release the first part in the early part of the week, and I'll release part 2 later in the week. So be on the lookout for not only this episode, but part 2 as well. Thanks for listening and enjoy. Andrew, I decided I had to have you back on the podcast. And the reason why is recently one of the nurses that I work with and I were talking, and we were talking about ACLS. And she told me she's a brand new nurse. And she told me that she just took ACLS, just took PALS, and she still feels like she didn't know anything. And she, during a code, she was like, I felt kind of lost and I felt like I didn't really know anything. And she's like, but I got the card. And I'm like, all right, I've got some suggestions for that. But I know someone who's going to have even more suggestions for that. And I was like, I thought to myself, that would be a pretty good episode, because my guess is she's not alone in that. My guess is there's a lot of people who complete ACLS, finish the ACLS course, and really don't have a whole lot of idea of what they're doing. Or some of the old nurses who've been around forever, maybe they just don't do resuscitations a whole lot. They are card-carrying ACLS, card-carrying people.
Fellow
Maybe if they don't do it all the time, they may have some questions and may not feel as comfortable as maybe they should. So I thought you would be the perfect person to get on, ask some questions, talk a little bit about ACLS and where to go from there, and maybe talk a little bit about some of these drugs that were given during ACLS.
Well, I appreciate the opportunity, Kevin. It's always good talking to you. I think I was maybe your third or fourth podcast when you first got started out. So it's been a little while. And
been a little while. So make sure you tell the audience who you are and what you do.
Sure. So I'm Andrew Bowman. I'm now celebrating my 41st year in emergency care. I started in 1982 as an EMT and in the state of Indiana. By 84, I was working as a medic for a 911 service in central Indiana. Decided I liked climate control. And so went to nursing school at Purdue in West Lafayette and got my baccalaureate degree in nursing in 1991. worked as an ER nurse, charge nurse, educator, preceptor for the emergency department, all of that on the night shift for about 24 years at a hospital up in Lafayette, Indiana. I decided I wanted to expand my capabilities, and so I enrolled in nurse practitioner school in 2007. Noticed that was about 16 years after I graduated nursing school, so I had a very good nursing background, which is what I emphasize to people who want to become advanced practice nurses. Work as a nurse for a while before you make that leap. But I've been working as I started nurse practitioner school, in 2004, graduated in 2007. And I've been working as a acute care nurse practitioner for an emergency medicine group in Central Indiana. And we cover 3 different hospitals, which are all community hospitals. They're not tertiary centers. They're not trauma centers. They're just your run-of-the-mill community hospital surrounding Indianapolis, about outside of that major center. So I still maintain my medic certifications. I'm one of 14 Indiana State EMS commissioners representing emergency nurses on that board. I'm the state rep for the American Academy of Emergency Nurse Practitioners for Indiana, and I'm the state chapter secretary for National Association of EMS Physicians, and then a member of the Academy of Emergency Nurses, just as you are too, my friend. But it's always been my favorite topic. It's always been resuscitation. Most of my lectures that I've given over the years to local, state, regional, national, and international audiences have been on resuscitation. I got invited to India back in 1998 to talk to a group of people in Hyderabad, India on resuscitation.
How cool is that?
Physician. So it's one of my favorite topics to read about. It's one of my favorite topics to talk about. One of my favorite topics to provide education for. So I'm hoping that our podcast today opens up some eyes to what may be better for their patient in cardiac arrest than what ACLS currently teaches.
Fantastic. I love it. And that's why I knew you were the right guy to talk to. So let's get into a little bit of ACLS. What you explained something to me that I guess I'd never really thought of this way, but tell the audience what you think of the ACLS guidelines and who are they for and what are they useful for?
Yeah. So American Heart's been doing these guidelines since the mid 1970s. I still have my original ACLS textbook from 19. So I took 1983 when I first took it, but it'd been around since 1935. It actually started out as just a supplement to a journal. It's maybe a 30-page, almost like a magazine is what it looked like. And expanded into, the book and textbook that it is today. And again, American Heart and the European Resuscitation Council and National Liaison Committee on Resuscitation, or ILCOR, they do a great job because there are thousands of people around the world doing research in resuscitation, from CPR to ventilation to drug therapy to more novel therapies like ECMO and things like that. And so they have to, consolidate volumes of information, look at the level of evidence. Is it a good study? Was it well done? Was it well performed? Did it meet the outcomes that were proposed? And then they have to kind of decide, how are we going to get this out to the masses? And so they do have to kind of dilute it down and, not maybe specifically this phrase, but, dumbing it down a little bit to what do they think at this point in time with what we know. What do we think works well? And so then every, couple of years, they come out with some new recommendations and guidelines. And it's actually better now than it used to be, where you had to wait at least 5 years before they dump the information. But now with the world of social media and, access to information, as soon as they get something new, they dump it out. So often as though every few months or every year, they'll put out some new recommendations that may be all broad, covering everything, or just maybe some focus things. They just came out recently with their guidelines for resuscitation of the poisoned patient, someone who's taken an accidental or intentional overdose of either opiates or cardiac medication or whatever that is causing your cardiac arrest. So they have recommendations. So that's just something new that came out that I'm diving into right now. So they do a good job of that. What I think is bad about ACLS is for someone like yourself or myself or many of our colleagues who have been doing emergency nursing for years, and who might work in facilities that see a code a day or a couple codes a day. ACLS doesn't really apply to them. So it never made sense to me to make those people every 2 years go through an ACLS course. Now, yes, they should be updated. If there's something new and novel that comes out, yeah, but to go through the same thing every 2 years, it's kind of depressing to me. I think we can make better use of those experienced nurses' times and give them a better format and more focused education on what's new and different. I've always said that ACLS is for your dentist. If your dentist is doing some, anesthesia for your root canal or what have you, and you have an, weird reaction, ACLS is going to guide that dentist in how to resuscitate you while you're calling 911 and getting things started. But ACLS is not for the practiced or seasoned resuscitationist. ACLS is there for the person who uses it infrequently, if at all. And when they need it, it does provide some very good information, very good guidelines on how to start the process. But it is not, it's the floor. It is not anywhere near the ceiling of information that a seasoned resuscitationist can have at hand to resuscitate.
I think that's a great way to describe it. I think for the experienced provider, I could see someone getting, and I've seen this in hospitals I worked at, where on the crash cart, it actually had the algorithms. They had a little book full of the algorithms.
Yeah.
It was like cardiac arrest, flip to this page. And the cardiac arrest, they basically put the algorithm in front of you, just in case you don't know, here's what you're going to do. And
we've got it on a big poster on our wall in one of our resuscitation rooms at one of the hospitals we work at, just because at one of the hospitals, we don't see it.
Yeah.
Community EMS works in the field, and if they don't get ROS within 30 minutes, they're done. So we don't see a lot of the patients that EMS actually goes out for. We get the ones that they've gotten at least temporarily a pulse back, and then they'll bring them in. So not all that like that. I still have one service that brings me the 90-year-old in asystole for 30 minutes.
Yeah,
so,
you're like,
not much I can do here, but thanks, guys.
Yeah, thanks for coming. Let's go ahead and call this now.
Yeah.
And I think I know frequently we do that in our organization. People get there and we're not super close to everything. So there's sometimes a little bit of transport time, and if they're 30 minutes out already, we're going to give it a try. We're going to give it the good college try. We're going to get a handful of meds and we're going to call it done.
Right.
So, all right. So what would you just say to someone who has taken the ACLS class and they really don't feel like they've learned, they don't feel like they've earned the card that they have in their pocket, right? And that's exactly what this young lady said to me. She said, "Hey, look, I have my ACLS card, still don't know anything."
I used to be an ACLS instructor for many, many, many years. And as I started changing formats in the early 2000s of, how they taught things, I kind of became disillusioned with that method of teaching, because I was always, when I was doing ACLS classes, when you had some freedom to, make it more unique, I would have it, the majority was hands-on. I had a good kind of all-encompassing lecture, but then the rest of the day was spent running code after code after code after code after code, and having the participants or my students in different roles, each time. So I think I would probably ask that nurse who comes to me and says, "Hey, I just finished ACLS, I got my card, I have no idea what I'm doing." First thing I would say is, did you read the book? That's where I think a lot of people fall down is, they get the book, they look at the algorithms, they memorize maybe the algorithms, for BFib or PEA systole, and they think that's all you have to do. So, the book has the science, it has the rationale, it has, the evidence. So you need to read the book. And so that's the first question I would ask. Second question I would ask is, why don't you feel prepared? Was there something lacking in your class? Did you don't think you got enough hands-on time? All you did was watch the videos. The instructor was the video remote controller, which drives me crazy, which is one of the reasons why I got out of teaching it. So, what was it about your class that you felt left you unprepared? And then thirdly, I'd probably say, what is it you think you don't know? And just run them through, let's just sit down and, patient arrives and they clutch their chest and they collapse. What are you going to do? And actually walk through them just to see how much they know. And I might surprise them how much they did retain.
Yeah.
because, you got the card, and like 2 days later, it's like, oh, they really know what I'm doing. We all suffer.
I, I certainly have been in that boat myself, where, you're like, okay, I just finished that, but I'm not sure I know how to do it. But
Right.
then I'm always surprised, like when, when the time comes, and I remember when I started in my job I'm in now, when I started my job now, and they said, I'd asked who runs the codes at night, and they're like, you do. And I was like, wow, like that's, a little bit intimidating to me, because I've always worked in hospitals where I had a doc saying, okay, doc, what are we going to do next? And the reality is in our ER, we have that. But on our floors, we don't. It's a nurse driven code. Um,
One of the
and
best jobs I ever had, kind of along those lines, was a new hospital opened up in town, and our group was covering the ER, but they needed someone at night to be available for codes only, because the ER doctors had in their contract because they were going to be so busy in the ER, they didn't want to have to leave the ER, especially if it was only single coverage at night, to go upstairs to run over who knows how long
yeah,
in an ER that they anticipated going to be very busy based upon where it was built. So for about a year, I had a part-time job where all I had to do was go in at night, carry a pager, carry a key to the elevator to override it, and respond to codes.
that's
That's
awesome.
all I had to do.
What
And
a great job.
I had a hospital room in a yet unused part of the hospital that they were still kind of working on. Had a hospital room, a bed, a recliner, a TV, a shower. It was awesome.
What a
And
great job. What a
it
great
paid great. And I didn't do squat.
That's awesome. That's awesome. Well, I know in my role now as an AOD, or what many folks may know as a house supervisor, we respond to the codes and we have residents there. But the reality is most of our residents have much less experience with ACLS than most of the nurses who also respond. We have our ICU nurse responds, ER if they don't have a whole lot going on, they may respond. And then mostly it's going to be the house supervisor and the nurses who are on that unit. Um, and for a long time it was, the house supervisor was going to be the one who kind of ran the code. And now it's kind of the residents running the code with the house supervisor kind of assisting, which to me means, like, hey, look at this rhythm. Here's what we're doing. Here's the algorithm we're on. Let's go ahead and keep going down this pathway. We're in the department. We have or let's say, let's even make it for the non-emergency nurse. We go into a patient's room. Suddenly we realize the patient is pulseless and apneic. What's going to be our priorities? Of course, we're going to call the code and call for help and do all that kind of things. But what's going to be our priority? Let's say we're in the emergency department. We know that there's a code rolling in. The minute they roll in, what's going to be our priorities?
So for that nurse on the floor, obviously she's going to call for help, hit the code button, and hopefully start the basics. She's checked for the pulse already, not for you. So there's something to be said, with that single person room, just start compressions. Don't worry about the airway right now. So, that lone nurse in that room up on med surg is going to start compressions, call for help, got to bring the code card to enter, get them on the monitor and see, what the rhythm is. Is there something shockable? If it is, shock them right away. The two things that definitely work that, all research points to is high quality CPR and early defibrillation. Those two, without fail, are the main things that are going to resuscitate your patient, regardless of the cause of their arrest. If they're not getting good CPR, if they're in a shockable rhythm and you don't recognize it, you don't shock it, they're not going to do well.
Yep.
Everything else we do is superfluous. Might help, it might not. A lot of the research is just showing these drugs, unless there's a specific thing like hyperkalemia where calcium and bicarb might be helpful, our drugs really aren't that great in the grand scheme of things. Epinephrine has been around since 1906 for resuscitation. It was first studied in dogs, and those studies were repeated in the early 1960s, again on dogs. And our 1 milligram every 3 to 5 minutes is based upon a 20-pound beagle.
Really?
And it hasn't changed since then.
Well, it's kind of funny because we think of, at least I've always thought of epinephrine as like the holy grail of ACLS meds. I mean,
And it
the
still is.
ACLS, it still is, but I didn't realize there was so little
Yeah.
background on it.
Now,
Or
epinephrine
research.
was studied a long time. Like I said, the first studies were in 1906. Again, dog studies. There's a study in 1963 from Cryle where they kind of, reinforce, if you've got a dog in cardiac arrest and you give a milligram of epi every 5 minutes, you're probably going to get a pulse. Now, since then, a lot of different other things have been studied. You probably remember the phase of high dose epinephrine. The town I used to work in, we had 2 EMS services that did 911 call. The other service was always the one going after that new shiny thing. If it was something new or different, they were doing.
Yep. We all know those doctors and or systems.
Yeah. And so when high dose epi came out, they leaped on that like white on rice. And so I remember the first time they brought us a patient to my ER, because both services, covered the whole town, whatever ER was closest. Said, we got this 65-year-old gentleman, cardiac arrest, blah, 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 blah. And he's had 61 milligrams of epinephrine. Because they gave the initial 1, and then they did the weight-based high-dose epi, so each subsequent dose was 20.
Ooh, doggy.
Wow, he's still dead. Okay, thanks. So, that fell out of favor then, understandably so, because we realized it didn't work. So now we're still back with the standard is still, and I like the way they say it. Let me pull up my note here real quick, so I want to get the verbiage perfectly correct. So the current guidelines from American Heart ACLS, we recommend that epinephrine be administered for patients in cardiac arrest. And it's got a level of evidence of B, so it's not the best. Based on the protocols, it is reasonable, quote, reasonable, to administer epinephrine 1 milligram every 3 to 5 minutes for cardiac arrest. Perhaps if you have initially a non-shockable rhythm, give it epi as soon as possible. But if it's a shockable rhythm, perhaps delaying it after the second shock, so as not to, persistent or precipitate more VFib. And then again, at the very bottom, high dose epinephrine is not recommended for routine use. So even the guidelines are not real strong. We recommend, and it's reasonable to give epi 1 milligram every 3 to 5 minutes intravenously or IO. Now, there are some services, EMS services in this country that are doing something a little bit different. They are extending the intervals on dosing epinephrine, especially for shockable rhythms like VFib, pulses, V10. There's a couple services that give 1 dose and then they're done, especially for shockable rhythms.
I hadn't heard that.
Yeah. Florida's one of them.
Does the evidence, what does the evidence show? Does the evidence show that like, is it
Again,
making a meaningful difference?
It's still being researched, but they're saying that, the Paramedic 2 trial out of London a couple of years ago showed that standard epinephrine dosing, as we just talked about, 1 every 3 to 5 minutes. Yeah, if you use epinephrine, because it was epinephrine versus placebo in the Paramedic 2 trial. If you use epinephrine, more people got return spontaneous circulation, they crossed, but there was no difference in good neuro outcome. You have people who are alive, quality of life is very.
So we got grandma's heart beating, but we didn't do her any favors.
And that goes back, in my mind, what I always try to think about is Dr. Peter Safar, who was one of the early, 1950s, 1960s researchers in resuscitation. CPR is for the heart and brain that is too good to die. And why I think about that all the time is, got a 35-year-old guy who's playing softball on the weekend and he collapses running to first base. Yeah, go full bore on that guy. Do everything.
Go nuts.
It's got a great quality of life to begin with. If we get CPR on scene, if there's an AED there, shock them early, you get 911 called, they do their thing in the hospital. That's going to be a great outcome. But then where we're seeing CPR still being used is, as you said, 90-year-old grandma who is demented from the nursing home, and the family wants everything done. And it just kills me to torture these people. So Dr. Safar got it right, 50, 60 years ago. Of when should CPR be applied? And it's not for everyone. And it's not trying to be mean or cherry picking patients, but there are certain patients that it's just not.
One of the things I've really kind of gotten in the habit of doing, and other people in my organization are picking this up, is when we talk to patients about resuscitation, we always talk about DNR, or do not resuscitate. And one of the things I've really kind of focused on is saying, call it allow a natural death, AND.
Right.
Because oftentimes what I remind folks is all this stuff we're doing is to prevent a natural death. And sometimes a natural death isn't a bad thing, and death isn't to be avoided. It can't be avoided. And sometimes, if today is the day, then today is the day. And if there's times that it's not, we're not. One of the things I always tell people is, we're not trying to suggest that you don't resuscitate your loved one, but understand, like, what are their chances of a meaningful recovery? And I think if every family had a chance to see what CPR looks like, see what a code looks like, most people would be like, oh, don't do that.
I mean, quality of life for someone who suffers cardiac arrest will never be any better than what it was before they went into cardiac arrest. Grandma's grandma who's demented and has recurrent pneumonias and UTIs is in the hospital every month. When she finally goes into cardiac arrest and we resuscitate her, she's still going to be grandma who's demented, is going to have pneumonia, UTI every month. She's not going to be any better than her pre-arrest baseline. And so I'm not sure, I'm sure TV and movies have played into this idea that, CPR is for everybody, because in all the TV shows, the success rates are like 80, 90%. Of
course.
In reality, across the board in this country, the average is about 9 to 10% good resuscitation, good neuro outcome.
Wow.
So it's vastly different than what people are seeing on their TV or in the movie theaters all the time.
Yeah.
So, there is a recent New York Times article, and I don't have it saved. I would have given you the link, where a guy does write about that thing where, we're doing CPR, people CPR should know. But, that's a whole different conversation from where we're starting here. So,
yeah.
So epinephrine, yes. American Heart does still recommend it, 1 milligram every 3 to 5 minutes. But again, it's a recommendation. It's reasonable to give that medicine. But just understand that for epinephrine, there might be some different dosing patterns. Giving the one time and done, perhaps widening out the interval, certainly delaying it in a shockable rhythm is very reasonable, because, if you get someone in VFib epi, you're probably going to just persist the VFib. And we'll talk about some other drugs for that situation here shortly. But some places are doing based upon end-tidal CO2 and starting an epinephrine drip. If they can keep the end-tidal CO2 up above like 30 or 40 on the drip, and that's great. Some ERs are putting in arterial lines and trying to get a diastolic pressure of above 40 with an epinephrine drip. So there are lots of different ways that we can utilize epinephrine. There's the old standby from American Heart, 1 every 3 to 5 minutes. But understand that once you're working in your ER, especially if it's a physician or provider who's up to speed on the research, you might see some different dosing patterns of using epinephrine. You might actually see a reduction in how much epinephrine.
I think one of the things we're seeing, one of the things I commonly see when we do codes is just your standard, epinephrine dose every 3 to 5.
Yeah. And that's safe and it's reasonable. And someone takes you to course and, well, I follow the guidelines. That's what it says. And so, you're safe. But again, there's different recommendations that are out there that aren't yet endorsed by American Heart. But again, American Heart's just guide, but not the law.
Right. What other medications do we commonly use in that code situation?
Okay. So let's stick with our patient who's in that persistent VSIB. We start CPR, we're managing their airway. We shock them appropriately. And that's the other thing, when you're doing your shocking, making sure that your pads are properly placed. When someone rolls in the door or, EMS finds someone, they're already laying on their back. It's easy to do those anterolateral placements, and that's perfectly fine.
Yeah.
But it's what people don't realize is, okay, so the anterior pad goes up on the right upper chest, just below the right clavicle. But where I see a lot of discrepancy, and which may lead to poor shock delivery, is where they put that lateral. I've seen that lateral pad all over the place. And you think about, what are we trying to do with defibrillation? We're trying to get a current of energy to flow through as much myocardium as possible. And so think about, where's your first pad? Where's your second pad? Is it making a straight line through as much heart as possible? So that lateral pad needs to be truly on the lateral chest wall, kind of in the mid-axillary line, and centered at around intercostal space 4 to 5. So
I was gonna say kind of like your 12 lead EKG, about 4 or 5, and
so like
intercostal
where you would
space.
put V6, your V6 lead,
Yeah.
that's where that lateral defibrillation pad should go. Because you want to try and get the heart right smack dab in the middle of that defibrillation current flow. Because defibrillation needs to depolarize as much myocardium as possible so that the heart stops. And then hopefully, pacemaker kicks in and you get a rhythm. And then hopefully that rhythm is producing some mechanical contraction and blood flow. And hey, we've succeeded. But I've seen the pads, placed all over the left side of the body, even down the lower abdominal wall. Sorry, guys, it's not going through the heart. Same thing if you're doing anterior posterior pads, making sure that the heart is between your pads. So front one is just to the left of the sternal border, and the posterior one is just to the left of the thoracic spine. So you're sandwiching the heart in between those pads to try and get as much current through as much myocardium as possible, so that you have to depolarize a critical mass of myocardium with your defibrillation shock for it to work.
And is there advantage to either posterior lateral, or anterior lateral?
Not if they're well placed. Overall, in the big scheme of things, no. Perhaps for an individual patient, like perhaps a very big obese patient, or maybe someone who's got bad COPD, has got this huge L chest where there's a lot of separation, then perhaps one pad position for that individual may be better. But in the grand scheme of things, as long as they're placed appropriately, there shouldn't be much difference between in the global scheme. For the individual patient, one thing I like to tease people with, or share an interesting story, is when I was getting my nursing degree, I did 4 semesters of biomedical engineering, and these were some great minds. These were some of the original big minds in medical engineering. They worked at NASA back in the 60s and helped them with their telemetry and stuff like that. But one thing I learned is, a lot of studies, a lot of stuff we do today is based upon animal research. And one thing I learned taking those biomedical classes is that puppies don't have VFib because they don't have enough critical mass of myocardium to persist VFib.
Interesting.
Yeah. And so I thought, okay, so what we took from that is you need to depolarize that critical mass of myocardium in your patient for defibrillation. So, but if they're a small puppy, then they're not going to have VFib on board. Little tidbit of knowledge there. So, defibrillation, as soon as you recognize a shockable rhythm, whether it's VFib, pulseless VTAC, first thing is get right back on the chest with your CPR. It's going to take a few seconds to get your defibrillator charge it up, yell clear, and that person doing compressions should take their hands off the chest about 2 inches. You shock, and they're right back on the chest. You want to keep those compression pauses to a minimum. And current recommendations are trying to keep those compression pauses to less than 10 seconds. So if you're charging your defibrillator, or let's say you've shocked them, you're doing CPRs, now it's been 2 minutes. Before that person stops, you pre-charge. Now your defibrillator's charging up, they're still doing compressions. Your defibrillator charges up. Stop CPR again, hands off, hovering 2 inches above. You see a CFib, you shock it right back on the chest. You don't wait to see what the rhythm is. You just go right back into CPR.
Absolutely.
So recharging while the person doing compressions helps to limit that compression pause. Because as soon as you stop doing compressions, blood pressure that you produced and blood flow you produced with compressions drops precipitously. So if we can keep that pause as short as possible, get right back on the chest, pressure's going to stay up.
Now, one thing, and I don't know if I'll leave this in the episode yet or not, but one thing that I remember years ago, a doctor I worked with was, we were talking, and he was saying, or, we were doing a code, and he was, doing compressions, and he said, he goes, all the studies are showing that you can shock. You don't even have to go hands off. You can shock with compressions with the new biphasic machines.
Right.
And he goes, so let's try it. And I was like, hold on, being the charge nurse that I was like, pause, let's talk this through for a minute. And I told the physician, I said, sir, understand, like, first, let's figure out, okay, do we have another physician here in case you go down? And he goes, really appreciate your concern for me, Kevin. And I go, no, really, do we have another physician here? We do. Okay, great. Understand if you do go down, you are going to be our second priority. We'll get to you, but you're going to be our second priority. We're going to finish. Yeah. We're going to have to get another team in
I
here.
thought we started.
And he just kind of laughed. He goes, no, it's going to be fine. So I was like, I wasn't an active part of the resuscitation. I was a charge nurse. And I was just kind of hovering going, okay, I'm going to supervise this for a minute. And sure enough, we charged to 200. He was doing compressions. He's like, okay, charging. I said, okay, everybody else clear. And we shocked. He got just the rigidity of the chest and just kept on going and didn't feel a thing at all. And then, of course, the tech was the next person who goes, oh, me next. When he jumped on the chest and we did end up shocking the patient again, and no effect at all, like no effect. Now,
Yeah, I've read those studies. I've listened to Scott Weingart talk about. Scott Weingart actually was the first person I read about doing it. He's a big EM critical care guy from out east.
Yep.
When he did it, he actually got a shot. That kind of let his arm numb for a while.
Interesting.
Okay. There's actually a video on YouTube that shows, a couple of, I think, that show it being done. Everything's obscure, it's got different colors and stuff to obscure any details, but I don't think we're there yet. What I last read, and I haven't read about it for a while, is, electrician's gloves will protect you. Who had those in their ER? Not me. Probably not really anybody.
No.
There is some thought that double gloving with just, your usual gloves would probably be okay.
That's what he did. That's what this doc did.
This is where your Lucas device comes in. If you got something, a machine, a Lucas or whatever other device you might use to do your mechanical compressions. Yeah, shock that all the time.
Absolutely.
I'm still not to the point myself where I would trust not giving, a shock. And again, since we do have devices that do that for us now, there's no reason to leave your hands on. But that's my opinion. No. I know some people have done it. Obviously, your doctor did it. So
yeah, I've seen it. I would feel comfortable doing it myself. Now, as a side note, I've heard a million times of different stories of someone who, these are all old paramedic stories, right? You're an old paramedic, so you'll appreciate these stories of the paramedic who was leaning against a stretcher, shocked himself, and now has a dysrhythmia. I heard, I know a guy who way back when, he shocked somebody and he was touching the stretcher and now he's got dysrhythmias, or he went down and he coded next. And the way you hear these stories a million times with the same story with a different name. And you just think to yourself, like, these sound like just old wives' tales.
Yeah. I think they are.
So.
Yeah, you might feel a tingle, you might feel shock, where like Weingart's hand was numb for a while, but
yeah, you're not going down. You're not going down. You're probably not going to have dysrhythmias, probably.
Now, the other thing about defibrillation that I think is exciting, in the Victorian Ambulance Service out of Australia, supposedly just finished up some research on it and bugging them for any details, but haven't got back to me yet. So you're an old school guy like myself. You remember paddles. Okay. Paddles might be coming back, but not in the way So what they were doing and what I've seen done and what I now do myself is if you still have your old paddles from your life pack or whatever thing you have laying around, they're in storage because you use pads all the time. Now you don't need them.
Yep.
Get them back out, put them somewhere on your code card because there's a lot of research that shows that manual pressure on those pads that you place on the patient, the self-adhesive pads that we have now instead of paddles. If you use your paddles or even your hands, because the back of those pads are, resistant. You're not going to feel a shock through the pad. Using your hands to apply that
little extra pressure,
25 pounds of pressure that we were taught in the early days of ACLS to kind of compress the chest, squeeze a little bit more air out because air is a poor conductor of electricity. So you want to try and get as much current flow as possible by forcing that air out. So you're using your hands on the pads or your old paddles on top of the pads and squeeze that 25 pounds of pressure. And some research has shown that improves shock delivery and successful conversion from a shockable rhythm.
Interesting.
And so last year, the Victorian Amputee Society out of Australia was researching it. And I think their protocol, and don't, hold me the quote on this, but I think it was like every other day. On some days we'll just use the pads. On the other days we'll use pressure, pads and pressure. And so the earlier research was showing that adding that pressure to those self-adhesive defibrillation pads improved recovery.
It's interesting because I remember as a director of an ER, the hospital got rid of all the pads throughout the hospital. I was part of the code committee, and then the code committee said, hey, you know what? We're using pads. We're not using paddles. Let's get rid of all the paddles. And there was a cardiologist who was quite disagreeable, but I remember her very clearly saying, you leave the paddles in the ER, you leave the paddles in wherever her clinic was. She's like, I want paddles. She's like, because the paddles work better than the pads. And I remember very clearly thinking to myself, oh, bullshit. And
She was
and
right.
she swore by it. And she was like, nope, paddles are going to work better. I always go for the paddles. And I'm like, the problem with the paddles is a lot of times, I don't know how many times we had the defibrillator and it had the pads or the paddles on there, and it always had that old gel pad taped to the top of the defibrillator. And by half the time it was dry. So, you just didn't get good conduction.
What I don't like about paddles anymore is, you waste time. So you got to bring them into the patient, and your placement's probably going to be inconsistent from
It's true.
shop to the next. So the pads there, you put them right place first time. So
It's
your
just done.
positions, but then use your fists or those paddles on top. So your position is consistent. Add that pressure to improve that delivery of that current flow and improve the chances that you're going to get a successful shock out of it.
Interesting. That's very interesting.
If you've thrown your paddles away, just use your gloved fists. Throw some pressure on top of those pads because it's not going to, those back of those pads are insulated. You're not going to get a shock that way because you're not touching the patient. You're just touching the insulated pad.
Yeah.
And you might do better. I do it for all my codes. I do it for all my cardioversions. Someone who's got rapid AFib or SVT that we're going to shock, get them sedated, and then we charge up and then come in with my hands and put some pressure, and it works great.
Hey everybody, Kevin McFarland here. This seems like a pretty good place to stop this episode, and we'll carry on the rest of this podcast in part 2 of the ACLS Deep Dive. Did you take any notes? Did you learn something new? If you did, leave a comment on social and let me know. Don't forget to come back later this week for part 2 of this great ACLS Deep Dive.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.